Now moving on towards the forelimb nerve injuries, that is the peripheral nerve injuries involved that we'll briefly going through in this section through the radial nerve palsy, median nerve palsy, and ulnar nerve palsy. What is radial nerve palsy? As you know, the radial nerve is actually goes on from the brachial plexus and it descends down into the arm posterior compartment through the ulnar humeral groove, and it passes through the groove eventually in form of splits in form of posterior atrocious nerve and eventually a lateral antebrachial cutaneous nerve. If depending upon if there is a low lesions can occur over here at the level of the wrist joint, that is the anatomical snuff box with injured scaphoid. If these are injured, then what would happen in case of low lesions? Usually the fractures or dislocations and iatrogenic lesions can occur. This mainly leads to clumsiness and weakness of extension of the hand and fingers, because usually the radial nerve of this hands muscles are affected because it has already given supply to the most of the extensor compartment in the forearm. If it's a high lesion, that is usually can occur in the groove of the humerus, where spiral groove in which the radial nerve courses through in the arm. This happens with the fracture of the humerus and can lead to, because all the muscles of the forearm extensor compartment can be paralyzed, as well as the extensors of the hand and the wrist can also be compromised. This will result in the wrist drop. There will be weakness or paralysis of the radial extensors and sensory loss as well over the lateral 1/3 of the radial side of the forearm. In the case of a very high lesion, this occurs in the axilla. This is usually by trauma, such as could be a gunshot or could be due to some kind of a stab wound, or classically is a saturated endocardial palsy. That is usually when the people get too drunk, their arm is actually hanging by the side with the crutches or the sharp end of the chair is pointing going into the axilla. This may result in eventually the radial nerve palsy. But this would not only paralyze the extensor of the forearm and the hand, but also the triceps as well. And this would how would we differentiate whether it's high nerve injury, it's a very high nerve injury, it's a low nerve injury. If tricep paralysis is present, then this would result in usually the very high nerve injury of the radial nerve. Coming to the treatment is, it could be grafting. Nerve can be, if it's more than 2.5 centimeter, nerve grafting can be done. If it's associated with a fracture of the humerus, then internal fixation of the humerus can be done. If it's only neuropraxia, then the surgery can be delayed till 3 months, and we see if the nerve function has been regained, then we don't need to do anything. But if it's an iatrogenic injury, then acute nerve repair can also be done if it's a sharp cut. But if it's more than 2.5 centimeter, then nerve grafting in 3 to 6 weeks can also be done. And when we have to wait for 3 months, when we can use as a cock-up splint, this has been used in which the passive wrist extension and forearm extension is being done, so that the joints remain supple and the muscle keep contracting and they do not atrophy. By the time 3 months has passed, when we can go for either nerve grafting, or by the 6 months time, we can go for some kind of tendon transfers as well. Coming to the ulnar nerve. Ulnar nerve is also a branch of the lower half of the brachial plexus, and when it exits out, it can lead to it can either get compressed in the cubital tunnel, leading to cubital tunnel syndrome, or it can get compressed at the wrist level in form of Guyon tunnel, leading to Guyon tunnel syndrome. The features in case if it's a low lesion, it's a Guyon tunnel syndrome. This leads to usually due to cuts on the shattered glass, numbness and claw head deformity, and hypothenor and atrocious wasting, and weak finger abduction of the, especially the little finger, because this introsci, the palmar adduction and dorsal abduction is being done by the introsci. Therefore, this pad and lap would be weak, and there will result in a positive Froment sign. If it's a high nerve injury, usually this is when the cubital tunnel, this is around the elbow, it can be either compressed in the arcade of sutures or due to fractures around the elbow joint with elbow fractures and dislocations. Usually ulnar half of the flexural profundus is paralyzed. As we know that FDP is actually muscle which supplies the first index finger and the middle finger is supplied with the median nerve, and the little finger and the ring finger is actually supplied by the ulnar nerve. So in case there's a word called as ulnar nerve paradox. This what actually happens is, although high nerve lesions are more problematic and have a poor prognosis, but the symptoms which appear are actually less severe. That is, when there is a Guyon tunnel syndrome, that is the nerve is lesion cut in the Guyon tunnel, this will lead to severe form of claw hand deformity. But if the cubital tunnel syndrome occurs, that is the nerve is actually cut or lacerated in the cubital tunnel, this also leads to paralysis of the FDP, which means instead of the severe FDP paralysis, this claw hand is actually reduced. This is termed as ulnar nerve paradox or high ulnar paradox. Therefore, there will be actually motor sensory loss as well, because intrinsic and umbilicals will be paralyzed. Hypothenar vesting would still be present. There may be associated ulnar neuritis as well. And then we have to differentiate whether it's at the lower level or higher level. And once we know what is the lesion, then and we know where is the lesion, then we can proceed toward the treatment. Treatment is actually, if it's arteriogenesis, this can be sutured divided nerve can be sutured back. But if it is due to the malunited fracture at the supracondylar level, then we can do the anterior transposition as well. Along with the physiotherapy, there is called a Zancoli procedure which can be done for the ulnar nerve as well. If it's more than 6 months, then we have to go for muscle transfers. Now, muscle transfers include extensor carpi radialis longus, which is supplied with the radial nerve, to intrinsic tendon transfers so that the intrinsic can function normally. Other options, extensor pollicis brevis or extensor indicis, which is also supplied by radial nerve to the introitious insertion so that the introitious can contract normally and some function of the hand can be restored and claw hand can be prevented. Then, as we know, if it's associated ulnar nerve injury, then median nerve would be intact. We can go for distal nerve transfer from anterior introitious nerve, which is actually towards the ulnar nerve, so that all the median nerve and ulnar nerve function is in unison, resulting in correction of the ulnar nerve palsy. Now coming to the median nerve, as you know, median nerve is actually courses through the forearm and then into the arm, eventually forming anterior introitious nerve and sending down into the carpal tunnel. It can get compromised at two levels, that is at the wrist level in form of carpal tunnel syndrome, or higher up, somewhere in the forearm or at the level of the elbow. So clinical features in case of it's a low lesion, it's the carpal tunnel syndrome include, it could be by cuts or carpal dislocations. No abduction of the thumb is possible because these thenar muscles are actually paralyzed. There's thenar eminence wasting, as you can appreciate it over here. There may be trophic changes. There may be this palms will be sweaty, and there may be hair loss over here in these areas as well. And if it's a high nerve injury, high lesions could be at the elbow or at the axillary level. This could be due to forearm fractures, paralysis of flexor and pronator muscles. Usually there is a pointing index sign in which the patient is actually pointing finger sign is called as, and the patient with this flexor digitorum superficialis and profundus are paralyzed. Therefore, the index finger is actually being pointed in extension. There may be associated trophic changes in forearm and arm as well, and distal joints may be in full extension because the flexion muscles are paralyzed. Therefore, the flexion at the wrist joint cannot occur, and extensors at the wrist and elbow are actually keeping it in extension. If it is an isolated anterior introitious nerve injury, now the only way to diagnose it is from the median nerve is that isolated anterior introitious nerve has no sensory supply. So it's actually supplying all this extreme layer, but supplying some muscles of the forearm. Its symptoms are actually similar to high nerve injury, but the only difference is that there is no sensory supply of anterior introitious nerve. And usually the cause of the brachial neuritis is usually follows a viral infection syndrome associated with shoulder girdle pain as well, because the whole of the brachial plexus neuritis may be present as well. As this, you can see, this is an OK sign which has been formed. At this sign, OK sign has been formed. If the patient has anterior introitious nerve paralysis, patient will unable to be form an OK sign, especially because the thumb thin arm muscles would be wasted. So coming to the treatment, if it's an acute injury, it could be suturing the nerve back, or it could be nerve grafting at 3 months to 6 months time. Then we can use some splints so that the muscle remains supple, joints remain supple, and some kind of intervention can be done. If it's after 6 months, then we have to move towards muscle transport. These include abductor digiti minimi, which can be rerouted as it is supplied by ulnar nerve, so that it can be rerouted in form of thinner eminence, and thumb position can be restored. Other includes transfer of flexor digitorum profundus of the index of the ring and middle little finger, because that is supplied by the ulnar nerve to the index at the middle finger, which is supplied by the tenotrochus nerve or median nerve. Or using of brachoradialis, which is supplied by radial nerve, and rerouting it so that the finger flexion and wrist flexion can be achieved. And the restoring pronation can be done by rerouting certain procedures so that the pronator quadratus, the function of the pronator teres, can be restored. Now, in this section, we have briefly gone to the ulnar, median, and radial nerve injuries. And we know that the general principles are the very same. If it's an acute arterogenic injury, we can suture it back. If it's more than 2.5 centimeter of lesion, then we have to use some form of a nerve graft. This could be done either at 3 to 6 weeks or at 3 months to 6 months. If in any case after 6 months the patient either comes after 6 months, or if the more than 6 months has elapsed, then for all these 3 nerves we have to move towards the tendon transverse. If it's an isolated ulnar nerve injury, we can use the muscle supplied by median and radial nerve and reroute them so that the ulnar nerve injury can be overcome. Keep watching sqadia.com. Thank you very much.